Good morning. Thank you so much for joining us for Winship Ground Rounds this morning. If you are an Emory University or healthcare employee and would like to receive a CME credit hour for attending the ground rounds, the access code today is 452627. And this can also be found in the chat feature at the bottom of your screen for our virtual attendees. If you have any issues with this webinar or the CME login, please send Margaret Jones an email or drop a note via the chat feature. This morning, it gives me great pleasure to welcome Dr. Saurabh Chawla. Dr. Chawla earned his medical degree and completed his surgical residency at the University of Delhi in New Delhi, India. He subsequently completed his internal medicine residency and gastroenterology fellowship training at the Cook County Hospital in Chicago, Illinois. He completed additional training in interventional endoscopy here at Emory University Hospital in Atlanta, Georgia. Dr. Chawla is a professor in the Division of Digestive Diseases of the Department of Medicine at Emory University School of Medicine, and he serves as the Director of Endoscopy at Emory St. Joseph's Hospital. He is actively involved in medical school teaching, resident and fellow training in gastroenterology as the Program Director of the Digestive Diseases Fellowship Program in the Department of Medicine here at Emory. A board-certified gastroenterologist, Dr. Chawla specializes in the endoscopic diagnosis and the treatment of pancreaticobiliary diseases and gastrointestinal malignancies. He is a member of the Cancer Prevention and Control Research Program here at Winship, and he holds multiple professional memberships with the American College of Gastroenterology, the American Gastroenterology Association, the American Society of Gastrointestinal Endoscopy, and the Georgia Gastroenterology and Endoscopic Society. Please welcome Dr. Chawla today for his talk on pancreatic cancer screening, moving the needle or a wild goose chase. Thank you.
Thank you, Dr. Winship, for the kind introduction. And good morning, everyone in person and those of you who are online. I must say this is the first grand rounds that I'm giving in person after COVID. So it certainly feels nice to be back in person and doing this in front of a live audience. Well, in front of a non-virtual audience, I would say. So the topic of my talk today is pancreatic cancer screening, and this is something that we've been working on for the last couple of years. And I intentionally labeled it a little provocatively because this is a developing science, and there is a lot of evidence that keeps emerging, and it's 2 steps forward, 1 step backward, as you shall see in this talk. But hopefully, we are definitely moving the needle here. So, Okay, so the outline of this talk is going to be that I will talk about some principles of cancer screening, talk about the burden of pancreatic cancer, discuss some evidence-based approaches to cancer screening, talk about some recommendations, cost effectiveness, talk about our experience and some of the stuff that we're doing for future directions. So the principles of cancer screening essentially derive from the principles for screening of disease that were laid down by Wilser and Yagna back in 1968 and adopted by the World Health Organization. And essentially, any disease that is an important health problem should be considered for screening. If the natural history is understood, it is recognizable at an early stage, you have a suitable test with which to screen, which is acceptable to the people, it's cost effective, and there is effective treatment. A few things to note is that the benefit should be more than harm, and it should not be something which should be done intermittently, but should have a regular schedule to make sure that disease is not mixed. And when we talk about looking at the tests, we obviously always talk about the sensitivity and specificity, but it's important to understand that the predictive values of screening tests are important because as you all know, that the predictive values can go down depending on the prevalence of the disease in the population. So in this graph, for example, let's see, there's a marker here. Yeah, that even a test with a great sensitivity and a specificity, but very low prevalence of disease will have a very low predictive value that can lead to a lot of false positives and consequently the risk of harm. And now when we talk about the natural history of pancreatic cancer, we are somewhere over here at this point of time where early pancreatic cancer is relatively asymptomatic, and therefore most of the disease is detected when it is unresectable or metastatic, which does not give us a lot of time to help our patients. But over the last 2 or 3 decades, we have understood the natural history a little better. We've understood that there are certain pre-malignant conditions in the pancreas which can be asymptomatic, and there are certain environmental and natural triggers which can lead to these pre-malignant conditions. And now what we are trying to do is trying to catch people in this preclinical stage so that we have better outcomes with treatment. So by itself, if you look at all the cancer burden in the world, pancreatic cancer is not a very high prevalence disease, in that it accounts for just about 3% of cancers in the United States and about 2.6% cancers worldwide. Moreover, it is a disease of the West because the prevalence is, or the incidence is much higher in the Western Hemisphere, in Western Europe and United States as compared to the rest of the world. And hence, a lot of research is focused on in the Western Hemisphere. And we've all seen this graph, which is rather dismal, which says that the incidence rates of pancreatic cancer are pretty similar to the mortality, suggesting that the median survival is about a year or less. And the cumulative 5-year relative survival is only about 12%. And this makes it, despite having such a low incidence rate and a low percentage of total number of cancers, it's the 3rd leading cause of cancer death in the United States and Europe, and projected to become the 2nd leading cause of cancer death by the end of this decade. But having said that, as I mentioned before, the incidence rates per 100,000 population are pretty low compared to other cancers, and the lifetime probability of developing this cancer is only about 1.7% or so. And for this reason, the United Services Preventive Services Task Force has looked at and evaluated screening for pancreatic cancer in the whole population in asymptomatic adults twice, once in 2004 and then in 2019 rather comprehensively. And in both these reviews, they have ruled against screening for pancreatic cancer because they feel that the harms from screening can outweigh the benefits. So this is the first part of the talk, really, that so far the recommendations are that we should not be screening for pancreatic cancer in all comers or in asymptomatic adults in the general population. However, since about the beginning of this century, since about the late 1990s or early 2000s, several groups have been looking at certain high-risk populations which have an increased risk of pancreatic cancer, and they have set up some screening protocols and have had reasonably good yields from these screening protocols. The problem with these studies were that these were either small, single, or multi-center studies. Each one of them had a little bit different screening protocol or different modalities that they used. There was different definitions of positive results and a wide variation of diagnostic yields. And so recognizing these deficiencies, an international consortium for pancreatic cancer screening was formed, and it's called the CAPS consortium. It was led by the Hopkins group, but had other centers involved as well. And what this consortium was tasked with in 2012 was to come up with certain recommendations on who should be screened, how should they be screened, what the goals and successful outcomes of a screening program should be, and when should surgery be performed in these patients, which is the eventual goal. And then this consortium gave updated recommendations based on new evidence in 2020. And I will be using this as an anchor to talk about some of the key points about pancreatic cancer screening. So what this consortium did, and has been agreed by other centers across the world, is that they defined high-risk individuals for pancreatic cancer screening as those with a more than 5% lifetime risk or a five-fold increased relative risk for pancreatic cancer. And this was based on their age, family history, and certain germline mutations. And so these are the mutations that were identified and the individuals that were identified for high risk as those having a higher risk of pancreatic cancer defined as more than 5% lifetime risk. And you can see over here that they fall into three main buckets. One is the familial pancreatic cancer, which is people who do not have a known genetic mutation, but they have at least two first-degree relatives or more than three relatives overall, and that puts them at a very high lifetime risk of pancreatic cancer, so these should be screened. Then there is the breast and ovarian cancer cohort with the BRCA and the PALB2 mutations. There is the colon cancer cohort with the Lynch mutations, and then there are a few other standalone mutations like CDKN2A, PRES1 is for hereditary pancreatitis, STK11 is for Peutz-Jeghers. And these are the other groups of people who fall at a higher risk for pancreatic cancer. Now, when we talk about surveillance for these people, prior studies have looked at everything from ERCPs to CT scans to MRIs and EUS. And ERCPs were discarded a long time ago because of risk of complications with post-ERCP pancreatitis and less sensitivity for smaller lesions, etc. And out of the CT scan, MR, and EUS, MR and EUS have emerged as complementary modalities which are fairly sensitive, and each of them have their own strengths. MRI is good for small cystic lesions, while EUS is the most sensitive for small solid lesions, especially T1 tumors, if you may, because it's been shown to be much better for less than 2 centimeter lesions. And of course, the big advantage of EUS is that sampling can be done at the time of EUS. So for surveillance modalities, the current recommendations are that EUS and MRI should be considered complementary, and most groups agree that recommendations should alternate between the two at regular intervals. Now, what about blood-based markers? So, for the longest time, we just had one tumor marker for pancreatic cancer, the CA19-9, and we know that it is, 10% of the population may be Lewis blood type antigen negative and may not express this marker. And even when it is expressed, it's usually a marker for prognosticating the burden of disease, and it's not been shown to be very sensitive for preclinical disease, if you may. So, studies have looked and found that it's only 60% sensitive 6 months prior to the clinical diagnosis of pancreatic cancer. And so by itself, it cannot be used as a standalone marker, and it can occasionally, and what we do is we use it as a supplementary marker when we find ambiguous imaging or imaging which is a little concerning but not definitive of pancreatic cancer, just as a surrogate marker to see if we can get more information over there. Another thing that has been well established over the last 5 years, I would say, is the using new onset diabetes as a paraneoplastic marker, if you may, for pancreatic cancer. And studies have shown that about 1% of patients with new onset diabetes, especially after the age of 50 or 60, will be diagnosed with pancreatic cancer within the next 3 years. So another thing that we are doing and has been accepted in most practice guidelines is to get a hemoglobin A1C or some sort of glucose testing done at least annually to see if the patient is developing impaired glucose control, because that can be linked with pancreatic cancer in certain high-risk individuals and should prompt closer surveillance. So we've talked about the screening modalities a little bit. What are the goals of surveillance in such a program for pancreatic cancer screening? So one obviously is to identify and treat precursor lesions and prevent cancer from developing. And the second is that if we are picking up cancer, we should be able to prevent mortality from pancreatic cancer. So to identify and treat precursor lesions, what we are looking for are IPMNs and PANNs, because those are the precursor lesions for pancreatic cancer. Now, IPMNs relatively easier to pick up on imaging, but pannins are not, because pannins can be microscopic for the most part, and then by the time they develop a mass which is picked up on imaging, it may be too advanced or may have converted to cancer. So for this reason, you have to look for some surrogate lesions which may suggest pannins, like localized lobularity or some aggregated cystic changes or something of that sort, but not easy to find. Another thing which has been taken as a win for pancreatic cancer screening, though it actually is purely incidental, is the neuroendocrine tumors. Now, neuroendocrine tumors are, as we screen more and more people, we find more of the nets, and we know that neuroendocrine tumors less than 1 centimeter in size are fairly benign and can be followed. But if we pick up neuroendocrine tumors from between 1 to 2 centimeters or greater than 2 centimeters, then certainly if we can intervene on them, we can definitely improve the prognosis. And the recommendations through NCCN are to intervene in tumors more than 2 centimeters in size, but recently a group looked at neuroendocrine tumors between 1 to 2 centimeters and found a much improved outcome if they were intervened surgically before they got to 2 centimeters in size. So that's something which is evolving and has been taken as one of the wins for pancreatic cancer screening. Now, of course, to prevent mortality from pancreatic cancer, it is well established that you have to detect early stage cancer, typically stage 1 cancer, which again, as I will show you, is a big challenge for screening. Now, I will caution you that when we start people on surveillance, we have to tell them that most people who are undergoing surveillance will have small changes in their pancreas, and their pancreas may not be completely normal. So small cysts may occur in about 40% of people, high-risk individuals who are undergoing surveillance. And most of these changes are fairly benign. And therefore, and this obviously will lead to a lot of anxiety in these patients. So they have to be reassured that small cystic changes may occur. And this is just something that may not have any consequence for them. So this is something to be aware of. Now, the surveillance intervals then depend on what we see on these people when we are surveilling them. So if it's a normal appearing pancreas or just some mild cystic changes, then typically we want a 12-month follow-up. But then the follow-ups get shorter depending on what we are seeing or with the risk of, the increased risk of these lesions, with consideration for surgical resection being if there are cystic lesions with certain worrisome features, like mural nodules, thickened walls, eccentric calcification, and so on, or some solid lesions, which are typically more than a centimeter, or they are associated with a main duct dilation, or of course, a positive FNA cytology. Similar to other things, the time of initiation of screening has all been lumped together, usually at about 50 years or 10 years younger than the earliest diagnosis in the family. And this is not really based on, the evidence that this is based on is usually derived from retrospective studies on when pancreatic cancer was diagnosed in the relatives who had these cancers. And then there are certain genetic mutations, such as the PRES1, which is linked with hereditary pancreatitis, STK11, and the CDK2NA, in which pancreatic cancer has been noticed to develop earlier than in the other mutations. And therefore, the screening in these groups should start a little earlier at about age 40 or so. So, what are the outcomes of screening? Because this is, of course, the most important thing when we are talking about a screening program or a screening protocol. So again, different groups have reported different outcomes. The one that I will talk about here, which are the most robust, if you may, are the ones that were reported by the CAPS consortium. Now, what the CAPS consortium has done is that they've done a series of 5 studies. The first 4 were done in Hopkins alone. And they had about 300 or 400 patients here. And then the 5th study was a large multi-center study involving 8 centers. And this had about 1,461 patients. So cumulative number of patients in the CAPS 1 to 5 consortiums was about 1,731. And they followed people for a median of about 2.8 years, which led to about 5,000 person years of surveillance. And what they found in their cohort was that they had 26 pancreatic cancers in about 1731 patients, which is about 5 PDACs in about 1,000 patient years, or translates to 1 PDAC in about 194 patients screened per year. So not a big number there. But what was exciting was that people who were screened, about 60% of them were stage 1, as against those who were not screened, where about 85% were stage 4. So the 5 years, the median survival for the screen detected PDACs was about 10 years, and a 5-year survival was 73%, which is astounding compared to what the current non-screen population is, which is the median survival is less than a year, 5-year survival is about 12%. Similarly, other meta-analysis looked at other smaller studies, and what they found was that the pooled yield for high-risk lesions was about 3.1%, and 60% of the PDACs detected were resectable, or versus less than 20% of those who were not screened. So overall, screening has been associated with good outcomes, although the yield is pretty low, if you may. So cost effectiveness of pancreatic screening was also looked at, and of course, this was looked at through some modeling studies. And I won't go into details over here, but what this study, and this is probably the only study that has looked at it, concluded was that MRI-based surveillance, which is MRI alone and EUS only if there are any worrisome changes, was cost effective for if there was a 5 to 20-fold increased risk of pancreatic cancer, and EUS-based surveillance was more cost effective if there was a more than 20-fold increased risk of pancreatic cancer, or if the MRI cost was more than 1,600, which I think it is now, at least at Emory. So, but again, I'll caution you that this was just a modeling study based on the Medicare reimbursement rates in 2018. And when they looked at cost effectiveness by age, they found that it was cost effective to screen individuals anytime after age 40, going up to age 75 or so. But again, this is one of the deficiencies about screening so far, that we don't have a cutoff for the end of screening for pancreatic cancer, given that the median age for pancreatic cancer in the United States is still about 70 or 71. So we've talked about how to screen, when to screen, who to screen. What are the limitations of screening, which is, again, one of the things of concern. So one thing that we've talked about is the low event rate, even in high-risk individuals. So various studies have noticed that there is only about 0.4 to 0.6 cancers in every 100 patient years screened. So that's a pretty low rate, and that can lead to screening fatigue and screening dropout. Another concerning thing which USPSTF was concerned about for non-high-risk individuals is the fact that because of screening, about 40 to 60 or 70% people underwent surgery for low-risk lesions, which they otherwise would not have had. So that's something which is obviously something that we have to look at and refine. And then third is that even with recommended surveillance, a lot of people end up having advanced stage disease when they're detected. So there was a large multi-center study that was published just last year that showed that of the 28 pancreatic cancers that were detected in a cohort of about 2,500 patients, about 75% of them were beyond PT1. So essentially, this was not really a success of screening, because cancer developed despite doing regular screening and advanced to beyond the T1 state within a year within the surveillance interval time. Similarly, another meta-analysis found that 58% of pancreatic neoplasia were more than PT1 at the time of detection. So what this suggests is that either we shorten the screening intervals, which is obviously very expensive to do, or we come up with better strategies to screen. So with that background, I'll give you a little bit of our Emory experience. So we started the Emory Pancreatic Cancer Screening Clinic about 2.5 years ago. And this is something that we're trying to organize screening into one clinic, but this is by no means the number of patients who are screened at Emory, because we are not enrolling all people who need screen for pancreatic cancer into this clinic purely for logistic reasons. And a lot of my colleagues in, at least in interventional GI, and I know medical oncology and surgical oncology have their panel of patients who they are screening. But the experience of this clinic has been that we have about 93 patients, and about 75% of these have a family history of pancreatic cancer. 30% of them have a personal history of cancer, most commonly breast cancer. It's a fairly robust clinic because when we set it up with the help of our genetic colleagues, and 80% of them have had met a geneticist, and the other 20%, for the most part, have had studies done for mutations outside and were referred to us. And interestingly, about 80% of our patients are females. Now, this is partly related to the fact that we get a lot of referrals from breast cancer because of BRCA mutations, but also because overall, as with every other screening, women are more forthcoming and more proactive about screening than men. Now, we have about 67% whites and 33% or so African Americans in our cohort, which is, again, very different from most international cohorts that are available. And about 34% of our patients are BRCA2, and then we have a smattering of other mutations, all other mutations that are known to have be associated with pancreatic cancer. Now, as I said, this is a purely clinic. It's not being studied under any grant or anything. And so far, we've had about 30% people who've come up for one surveillance visit, and the repeat surveillance has dropped to 16 and 11%. And this is possibly because they've not reached the time for surveillance yet, or because of some surveillance fatigue, cost of screening, because this is not covered. This has to be borne by the insurance, and they have to do co-pays, etc. But the mean follow-up so far has been about 24 months. And what we found, similar to the prevalent literature, is that purely normal scans or EUSs have been seen in 35% only. So about 65% of our patients have had some sort of abnormality, if you may, out of which about 5% have pancreatic divisum, which is just a congenital anomaly. We don't even consider that an abnormality yet, so they can be put in with the 35%, so that's about 40% people. About 30% or so have had some sort of cyst, whether they are branch duct IPMNs or small cysts in the pancreas, which can be associated in these patients, and we know them. And the only pre-malignant condition we've identified is one main duct IPMN. But understand that it's 93 patients we've followed with a median follow-up of about 2 years or 24 months. And our outcomes are pretty similar to what has been published in larger studies. But clearly, this is not enough, right? We just talked about the limitations of screening in the fact that there is a low event rate, and the fact that early cancers are missed. And if surgeries are done, there's a fair number of surgeries which are done for low-risk lesions. So what can be done in the future? So there's a lot of work that is being done on liquid biopsies, which is circulating tumor DNAs, mRNAs, even microbiota, CTCs and microRNAs. So there's a lot of work being done over here. There is renewed interest in coming up with new imaging protocols, whether it is a limited MR protocol for the pancreas or a low radiation CT, which is a high sensitivity CT for the pancreas. Of course, using or leveraging artificial intelligence to go through the amount of data that is generated through all these tests. And then renewed interest in metabolic screening. So I talked about new onset diabetes mellitus, and there is a NIH multi-center study which has been started for this. But also sarcopenia has now been recognized as one of the in preclinical stages. So people who are getting their scans can get their abdominal wall fat measurement, or even the fat measurement around organs done using artificial intelligence. And if there is a change in that, that could be a precursor to pancreatic cancer. So lots of work is going on, but there are certain challenges. So one of the challenges of liquid biopsies is that the circulating tumor DNA, for example, just has about a 30 to 40% sensitivity at 99% specificity. And most of the studies, as they do, is they look at all cases, stage 1 to stage 4 in the derivation and validation cohorts. And we know that the amount of ctDNA in the blood goes down as the size of the lesion goes down. So for a stage 1 lesion, which is typically less than 2 centimeters, only about in about 10 ml of blood, there's only about 1 genome or less than 1 genome which is there. So the likelihood of detection in a very early stage is low. And for this reason, so there was one blood-based test that was commercialized and available in the market. It was called the Emory PanCan-D test, and now it has been withdrawn. According to the CEO of the company, and we were in talks with him, is because they wanted to make a more robust test, and they didn't give us the exact reasons why it was withdrawn. And then I'm sure you all have heard about this test, the Gallery test by Grail, which is single blood-based test to check for multiple cancers, and it's reported to have a reasonably good sensitivity for pancreas and bile duct cancers. But the sensitivity for early stage cancers, even in this test, is fairly low at around 20%, with the overall positive predictive value of less than 40%. So again, it's not FDA approved, and it's not something that we recommend because it, so far there's no data that is very useful for early stage cancers. So in the next few minutes, I'll talk about the work that Dr. Bhasin and his lab have been doing in pancreatic cancer and our collaboration with them. So his lab specializes in the omics technology, and before they moved down to Atlanta, in Boston, they had started working on trying to develop markers for pancreatic cancer. And what they did was they looked at all the published studies, came up with some markers based on existing literature. So initially, they identified 5 markers which performed gene-based markers which performed very well, and on the heat maps were very accurate in picking up cancer in certain cohorts. They then validated them and found that these markers were pretty robust in performance and actually translated into improved IHC-based diagnosis as well. And then when they validated them on independent cohorts of initially 30 patients and then 90 patients, they continued to perform with high sensitivity and specificity with a very good predictive value, a positive predictive value. Again, remember that these are all stages. So then they further try to refine it to differentiate it from early lesions and pancreatitis. And again, they had reasonably good performance. And this, of course, marker, as expected, outperformed CA99 across all cohorts of normal versus pancreatic cancer, normal versus precancerous lesions, and to differentiate between chronic pancreatitis and pancreatic cancer, much better than CA99 does. Then they further refined this to develop a marker which was based on 9 different genes. And then they are looking to validate it on tissue and blood. And again, based on preliminary studies, this is shown to have a very good ROC curve for detecting pancreatic cancer. And again, this has been shown, and these are all fancy graphs that Manoj shared with me, so I'm by no means an expert at this. But just looking at these and understanding a little bit about these, they seem to be performing very well. So currently, we are in the stage of prospectively collecting data to validate this marker, and we have some pilot level data, and we are applying for a grant based on this. But we want to take it a step further, and we also looked at diagnosing pancreatic cancer with machine learning. And so the hypothesis of this was that an AI-based algorithm would segment the lesions and extract image features with a higher precision than traditional methods. So to do this, we created a model where we shared some EUS-based images, and this is an image of a mass in the pancreas on EUS. And then we annotated it manually, and then we derived a model to predict the lesion based on the information that we fed in. We tried it across a series of 5 patients, and it seems to have worked very well in identifying lesions both in a single patient and in a cohort of patients with a very good heat map. And again, based on the prelim model, it's returned as an accuracy rate of over 90%, which is really good. But again, this is how AI works. With the initial training and validation cohorts, the accuracy rates are really good, but in real world analysis, then they sometimes drop off. But our eventual hope is to combine the radiomics and genomics using artificial intelligence to improve the accuracy of PDAC diagnosis. So what we want to do is use imaging data from EUS and also from MRI, combine it with the genomics data to see if we can come up with signals which would help in better predicting these cancers. And this is something that we are looking to apply for as a grant. Another thing that we have to recognize is one of the limitations of these studies is that the incidence rate is so low that single center studies do not work very well. And this has been recognized, and therefore a consortium was formed, which is the PRECEDE, which is the Pancreatic Cancer Early Detection Consortium. So this is a consortium of 40 centers worldwide. And the goal is to do an international observational longitudinal prospective cohort study with serial biosample collection and standardization of clinical and imaging data in high-risk individuals. The goal is to go big and get an enrollment of 10,000 people worldwide to accelerate the whole process, whether it's defining clinical outcomes using radiomics, genomics, so that we can come up with concrete recommendations in the next 5 years or 5 to 10 years with the goal of decreasing or improving 5-year survival of pancreatic cancer to 50%. So it's a very ambitious goal, but and we are glad that Emory is going to be a part of this consortium. But this does leave a lot of unanswered questions. So we know that even in high-risk individuals, cancer develops in only about 5% of these patients. So what is the role of phenotypic expression of these genes? Are there any environmental triggers? The biggest controversy that is raging right now is that we have so many people with BRCA mutations, and the current CAPS consortium recommendations are to screen people with a family history of pancreatic cancer. But what is the role of family history in people who don't know their family history? And also certain meta-analyses have shown that the risk of pancreatic cancer and BRCA mutations is not related to family history. So one of our societies, the ASGE, has given guidelines which say that all patients with BRCA mutation should be screened for pancreatic cancer beyond a certain age. And that obviously leads to a whole host of logistic questions and cost effectiveness and so on. So that's something that needs to be explored. What if a person comes in with an index mutation and no family history? How are you supposed to screen for these patients? I mentioned environmental factors. We've seen that the screening intervals may be too long, and that is the reason why we're not picking up T1 stage tumors. So either we improve our screening modalities to pick up precancerous changes, or we decrease the screening intervals. And all of these, again, come at a cost. And then, of course, when to stop surveillance. So a lot of topics where we can do further studies, collaborate, and a lot of unanswered questions. So to conclude, when I come back to the principles of cancer screening, we do recognize, and it's been well established, that pancreatic cancer is an important health problem. But the natural history is probably not as well understood as we would want it to be, and which is the reason why we are not able to diagnose these precursor lesions as well. It is recognized, it's much better recognized now than it was before, but it is still not recognized at as early stage as we would want to. A screening test is available, but is it suitable? That is still debated based on what we've seen. The screening test is acceptable to the population of interest, yes, within the caveat that it's not covered by some insurances, so people have to do a lot of co-pays. So that's something that we need to work upon. An effective treatment, the treatments are getting much better for pancreatic cancer, but we still have limited survival for this disease. So there is work that needs to be done there. We've seen that a lot of people are undergoing surgery for benign conditions. So the harm versus benefit of screening needs to be further refined. And then the cost versus benefit to the healthcare system still needs to be processed upon. So pancreatic cancer screening is by no means an exact science, but I feel that in the last 5 years, we've definitely moved the needle. And right now, we are in the process of major breakthroughs through international collaborations and through leveraging artificial intelligence, genomics to come up with better outcomes for our patients. So I want to end the talk here, and I want to acknowledge my partners, and it would be unfair for me to list any single person here because pancreatic cancer screening is a labor of love, and it's not just us in GI, but it's like my colleagues in genetics, in surgical oncology, Dr. Alisi and his team in GI oncology, the Basin lab with bioinformatics, my partners in radiology who I call on frequently to ask them to review MRIs for me to make sure that nothing is being missed. And of course, our pathologists who help us with FNAs, et cetera, and so on. So I would like to acknowledge all my partners over here, and I'm happy to take questions. Thank you.
Thank you very much, Dr. Chawla. For the audience, especially those online, if you have any questions, please use the Q&A feature that is located at the bottom of your screen. But we'll start with some of the questions in the room. Dr. Ramalinga.
Saurabh, thank you so much. That was a very comprehensive review of existing evidence to consider pancreatic cancer surveillance and screening. So my question goes back to something you mentioned. How do you alter the natural history of the disease? If you can't do that, screening does not have a role. And in cancers where we screen patients, the survival, if you detect and treat stage 1 disease, is 80 to 90% or even higher. In pancreatic cancer, even if you're diagnosed with stage 1 and go through a radical surgery, the survival rates are nowhere close to the 80, 90% as I understand. While I understand the reason how bad a disease is pancreatic cancer, we really need some ways to get it early so we can reduce morbidity and mortality. How do you reconcile that with the fact that we still don't have high survival rates, even if you pick it up early? So what's the point?
So, I think Lisi can speak better to the survival rates currently in stage 1 pancreatic cancer, but I believe they are getting much better now. And based on the CAPS consortium data, the median survival for screen-detected pancreatic cancer was close to 10 years. So I think true historically, the survival rates or the recurrence rates in people who got operated for T1, T2 cancers was fairly high, but I think that is changing now with better recognition of what T1 is and better chemotherapy there. So certainly, I think that has changed over the last few years. The second question was the natural history, I believe, is what you asked about. So yeah, again, and this is really interesting, is that we are doing a lot of pre-cancer surgeries now. And this is for detection of main duct IPMNs or high-risk side branch IPMNs or certain mucinous cysts and so on. And those probably don't make it to this data, but I think that is definitely changing things. And the only way we can do that is through better detection. And a lot of these people are getting detected through incidental CAT scans or something. So CAT scans which were done for, say, a kidney stone when they went to the ER and they got a non-contrast CT and that showed a slight dilation of pancreatic duct, and the radiologists are getting more aware, so they're picking it up. So I think there are subtle or slow changes that are happening which are helping us detect certain preclinical lesions. In terms of when we're talking about high-risk individuals, I think just recognizing the fact that these people may be a little different from others and having a heightened sensitivity would allow us to change their natural history as well. Now, another thing that I was talking to Dr. Lees and Dr. Lawson about was that this is one group of people who have seen their family members go through pancreatic cancer and they've seen how dismal the prognosis was. So they are highly committed by themselves. So they are the people who come to us and say, enroll me in any study that you're having. I'm willing to give blood. I'm willing to get a scan. I'm willing to do anything if you tell me that things are going and moving forward and we can find changes. So it's very interesting that, a subgroup of these people are very invested in trying to pick this up early, because for them, they are walking around with a sword on their, on their head, basically. And I keep telling them that even if you are at a higher risk, your absolute risk for pancreatic cancer is still fairly low. So you shouldn't be as anxious about it, but there is a high degree of anxiety in these people as well. Yeah.
The criteria for what constitutes what is the test that really helps the preventative aspect. And I see the challenges to be those people who you want to define as the real high risk, and what are the challenges with the serial monitoring, and what are the tests to use. So if you go back to the incidence, like you have close to 55 to 60,000 people, and these patients, majority of them, even though they're progress, like they're high grade at the time of high stage at the time of diagnosis, there's a small group of patients that see those long-term benefits, right? So from the numbers that you quoted, it was around 12% at the 5-year mark. So that's not a small chunk of patients. It's close to 6,000 to 7,000 patients in a year. And after certain time points, you call them cured, and the surveillance is where you can derive a lot of data from. The surveillance is where you can derive a lot of data from. This is probably the secondary surveillance. And are there any efforts in that space where you're asking if you people to go randomizing patients to go at surveillance with frequent intervals, and where exactly you're using the ctDNA and all these markers to see the recurrence?
So I think that's an excellent idea, and I certainly am not following these patients. I'm not aware of any work being done in that data, because post-resection and post-cure for pancreatic cancer, I honestly have just seen 2 patients in my clinic in the last 10 years who are 10 years out and who came to me. And I believe I talked to you about one of these patients, and we were like, there is no guidelines on how to do these patients. So certainly there is, work to be done there that we are not aware of. I don't know if you're aware of anything on those patients. No. Yeah. Hey, Dr.
Thank you. Incredible talk. You went through some of the previous screening studies, and you mentioned that many of them were single institution or small sample size. I'm wondering if there were any that, and you said the yield was pretty low. I'm wondering if there were any that actually looked at what would be considered the gold standard in screening, which is QALY, or quality adjusted life years. That's my first question. And then the second is, not every patient who has a family member is going to come here and say, hey, I want to do anything possible. And so a lot of those people will depend on their primary care providers and, family histories and those sorts of things. So I'm just wondering if there are initiatives to make PCPs more familiar with some of these, or kind of what is the space on that?
Right. So going to your first question again about the smaller studies that were done before. So the gold standard studies were the CAP studies that I quoted, because I think that was done more in a more organized fashion, and their outcomes were, fairly robust, and they have been replicated in other studies. The problem with single center studies were the yields were very good in some of these, and some of them they were 0. And so it was with much trepidation that I was looking at our data as well. And as you can see, our yields about 1% as well for 2 years of surveillance. So the yields are low to begin with, but it's also because, we are screening people from the age of 40 or 50 onwards. And so a bunch of my median age in my cohort is about 53 years. So, and we don't know when cancer is going to strike them, right? Because the median age of pancreatic cancer is about 71. So if I follow this group for the next 20 years, then suddenly I might spike from 1% to 5% at about age 60, or 10 years younger than their family member's cancer. So that part is not known, and that is one of the limitations of studies so far, because they have stopped at 1 year, 2 years, and the caps followed them for 5 years. And now when you combine caps 1 to 4 to now, then they have a good, follow-up of about 10 years or so. So that's one of the limitations that, we don't understand. And then second, the next question is really important, is about, awareness of this. So a lot of patients that come to my clinic are coming from the genetics clinic, because we are working with them. And when they recognize someone comes to them, they have a mutation, they take a pedigree, they realize there is a family history of pancreatic cancer, is when they get channeled to our clinic. The real time problems are logistics. So, there is a bottleneck of getting people in, resources, getting them MRIs, EUSs, and the fact that it is not covered by insurance. So for someone who doesn't have any other copay, we ask them to do an MRI, suddenly they're stuck with a very big bill. And, some of them will do it once, but then they'll be like, I can't do it on an annual basis or something. And a couple of PCPs have reached out to me and, oh, you're running this clinic, but why am my patient getting copay? I thought you were doing it under a grant of some sort. So, those are some of the real-time issues that we are facing as well. Or sometimes the insurance denies an MRI or a EUS because they feel that there's not enough data on this. I think there's a question in the audience. So there is a plan. We are working towards a grant. But again, once we get onboarded with pre-seed and we find the funding, we will start biobanking their blood. And through that, we hope to be able to do studies on that in the future. Dr. Lawson, you had a question?
The surgery. Is there any thought about neoadjuvant therapy, or is a way to learn something about, if nothing else, to learn something about this? I recognize it's the heterogeneous group too.
So I think for people who are diagnosed with pancreatic cancer, it's my understanding that Emory is that we offer neoadjuvant to almost all of them now.
Correct.
For which is very different. So I was recently at the International Association of Pancreatology meeting in India, and there, even now, they are not offering neoadjuvant therapy for stage 1 cancers. They're still taking them for surgery directly. So there's a big difference in practice between different places. But I think here we are offering neoadjuvant to almost all our patients.
While we're waiting on additional questions, I would like to mention that next week there will be no ground rounds. And to view all upcoming Winship ground rounds, please visit the ground rounds page on the Winship Cancer Center website or the Winship calendar. Are there additional questions either from the audience live or online? If not, thank you very much again, Dr. Chawla. It's been a pleasure listening to your talk. And we'll see you in 2 weeks. Thank you.